the patient. For the medical service current consultation, patients are consulted via PIGAR. Use of the pain characterizes currently with a pain scale of 68 associated with loneliness. Patient was prescribed to use and was sent home. The interim patient was able to take care, which provided temporary relief. Said stool was yellowish, following the future. Patient of the recurrence of chronic related vaccination. Patient applied anti-vaccination which provided no relief. Symptoms persisted, hence result for consulted PIGAR again. For the rest medical patient is possible to hospital. For the past history, immunization is patient cannot be followed by stroke or several floating positively and type 2 because of it. Personal examples is due to patients smoker stopped last December 2017 is an occasional holiday restriction. He denies addiction to alcohol and has a conflict with many cups a day. Let's stop function with vaccine. For the condition of the patient, his father has diabetes mellitus and was baseline his father, which further ROS, there were no complaints with skin and eyes near stroke. No complaints with breast. Cardiovascular cardiovascular is complained of terminal dysuria and increased frequency of urination. No complaints in the genital, peripheral, muscular, muscle bones, joints like kaya, click, and neurologic as well as hematological system.
General appraisal of the patient is awake, alert to person, place, and time, conversant, and no signs of distress. For the vital signs, we have BP 110/60, the temperature is 36.5 degrees Celsius, pulse rate 81 bpm, respiratory rate is 20 bpm, oxygen sat is 100% RA. For the anthropometric measurements, the patient is 5'10 or 178 cm, 80 kilograms, and his BMI is 25.2, which is considered overweight. For the oral examinations, we have first the extraoral. Symmetry of the face is symmetrical. On the TMJ, there is clicking sound and absence of swelling or pain. Lip has no cracks or ulcers. Lymph node is not palpable, and the facial profile of the patient is convex. For the intraoral examinations, the oral hygiene of the patient is poor. Gingiva is pink and firm. No pathological condition was found. The tongue is normal. The patient has a class 2 occlusion. For the physical exam of the patient, it shows normal. According to the residents, the patient has pink conjunctiva, clear breath sounds, normal rate and rhythm, flabby abdomen, soft, non-tender, tympanitic on all quadrants, normal active bowel sounds, negative succussion, splash, full pulses, no cyanosis, no edema. For the assessment in dental, it is symptomatic irreversible pulpitis. For the medical assessment, according to the clinical clerk, chronic kidney failure stage 4. As for the resident's assessment, we have chronic kidney disease stage 5, secondary to diabetic nephropathy and hypertensive nephrosclerosis. For the diagnostic plan in dental, we have periapical x-ray, percussion, palpation, mobility test, and for the medical, we have CBC test, sodium potassium test, ICA, magnesium, and CREA. The treatment plan for non-pharmacological in dental, we have oral prophylaxis, root canal therapy or close extraction, restoration, and recall. For the medical, we have for daily BP monitoring at home and record, for daily blood glucose monitoring at home and record. Advise proper diet and exercise. Avoid caffeinated and alcoholic beverages. Avoid oily and fatty foods. Increase oral fluid intake to at least 2 liters per day. While for the treatment plan in pharmacological, we have in dental, pain reliever, specifically mefenamic acid 500 mg every 6 hours as needed. Antibiotic therapy, amoxicillin 500 mg every 8 hours for 7 days. And for the medical, for start, we have Prazole plus 1 tablet 13 minutes before breakfast for 2 weeks. Flumasil 600 mg per tablet, 1 tablet twice a day. Then hold the losartan, hold metformin. To continue, we have aspirin 100 mg per tablet, 1 tablet once a day. Atorvastatin 80 mg per tablet, 1 tablet once a day. Metformin 500 mg per tablet, 1 tablet thrice a day, and insulin 70/30, 26 units subcutaneous in AM and 14 units subcutaneous in PM.
Journal. The journal that we have chosen is Association of Dental and Periodontal Disease with Chronic Kidney Disease in Patients with a Single Tertiary Care Center in Thailand. Volume 6, Issue 7, and published last 2016. The background of the study: several studies have shown an association between oral disease and chronic kidney disease, and regular oral care may be an important strategy for reducing the burden of CKD. Chronic kidney disease, the gradually and usually permanent reduction of the glomerular filtration rate of the kidney, leads to increase in serum creatinine and blood urea nitrogen levels, resulting in urea and azotemia. Common causes of CKD are hypertension, diabetes, chronic glomerulopathies, obstructive uropathy, autoimmune disease, and obex. Researchers' objective: to evaluate the association between dental and periodontal disease in Thai patients with various stages of CKD. Methodology: this was designed as a cross-sectional study and was performed between 2011 and 2012. The inclusion criteria were age greater than 20 years and a diagnosis of CKD for at least 90 days. Results: a total of 129 patients with different stages of CKD were included. 76 were men. The age range were 30 to 86 years old. The decay, missing and filling tooth index, and the number of missing teeth were higher in the group with moderate CKD than in the control group. Serum albumin levels decreased when estimated glomerular filtration rate was declining. Severe periodontitis was significantly higher in the more severe CKD group than in the less severe CKD group. Severe periodontitis and brushing teeth were more than once a day were associated with hypoalbuminemia. Conclusion: accounting for the immunity of the patient with CKD, this study reveals that patients with more severe CKD have more severe periodontal disease than those with less severe CKD. Severe periodontitis is also associated with the hypoalbuminemia from the early stages of CKD. Routine dental examination and proper preventive dental care are suggested for patients with CKD, especially in the early stages of the disease. Dental relevance to dentistry students: serostomia, uremic stomatitis, periodontal disease, and maxillary mandibular radiograph alterations can be observed in patients with chronic renal failure. Periodontal disease are highly prevalent among patients with chronic renal failure, especially gingivitis, excessive plaque formation, and poor oral hygiene in uremic patients. However, there are previous reports that periodontal disease and other dental problems such as loss of teeth, periapical lesions, and mucosal lesions are contradictory findings. Further study is needed. Thank you.